Okay, we're right at 10 o'clock and we have 210 people participating today. So I think we'll get started and make best use of this hour that we have in front of us. So hello and welcome everybody to the Best Practices for Co-occurring Disorders Treatment, Organizational Structure, and Service Environment. This is it's a five-part series hosted by the Great Lakes, Northeast and Caribbean, and Northwest Addiction Technology Transfer Centers, and the Great Lake Mental Health Technology Transfer Center. This is the second in the series following last month's presentation titled Defining and Assessing Integrated Behavioral Health Capacity. My name is David Jesperson. I am the Director of Training and Technical Assistance for the Northwest ATTC, and I'll be your moderator today. On the next slide, you'll see the map of the addiction and mental health training centers across the nation. These are a significant source of resource for your areas, and they're at your fingertips. If somebody would please advance to the next slide, please. Meg, is that you can advance? Thank you very much. I appreciate that. At the end of today's presentation, there will be surveys, and I'm going to tell you a little bit more about certificates, but I'll do that a little later. If you have any questions, please put those in the question and answer box at the bottom of your screen. Michael, Dina, and Travis will take some of those as we go along, and those that aren't answered, we will get those at the end of the session. So, and please also feel free to use the chat box as we go along, and you can feel free to drop in some comments there. All of us will be watching those as the session moves forward. Next, let me do some introductions. First, I'd like to introduce Mike Chappell. He's a PhD, Northeast and Caribbean ATTC Director and Associate Professor of Clinical Psychiatry at the New York State Psychiatric Institute, Division of Substance Use Disorders and Columbia University Medical Center. Prior to transition to NYSPI in May 2019, Dr. Chappell held a dual appointment as Executive Director of the Training Institute and Director of the Center for the Integration of Research and Practice at the National Development and Research Institute, where he's worked for the past 20 years. Welcome, Michael Chappell. And then my good friend, Dina Vandersloot, who's the co-director of the Northwest ATTC. She has provided numerous DDCAT assessments and coachings to dozens of providers in Washington and Oregon with over 10 years experience in this area. Her expertise also include motivational interviewing, integrated treatment, expert, and NIATEX improvement. Welcome, Dina. And we have Travis Swiringa, is the CEO of Interact of Michigan. Interact has 5 assertive community treatment IDTT teams in 2 different cities and provides an array of other services, including a full fidelity, nationally certified dialectical behavioral therapy program and first episode psychosis treatment. Travis has worked with an ACT team in the public health mental health system since 1994. He was supervisor of one of the first teams in the state of Michigan to have an ACT IDDT MyFast review. He has traveled around the state as a MyFast reviewer for the past 4 years. Travis, welcome. Glad to have you here today. And with all that, I'll turn it over now to Michael, and it's all yours.
Thank you, David. Appreciate that. Good morning to those on the Mountain and Pacific time, and good afternoon to everyone else. We very much appreciate you attending this session. I don't have any way of determining who had attended the first session at this point, so I will sort of give you a very, very brief overview of the DDCAT, DDCMHT now. Dual diagnosis capability in addiction treatment, dual diagnosis capability in mental health treatment is what the acronyms stand for. Essentially, these are assessment tools for determining the extent to which a particular program, whether licensed to provide mental health or substance use services, integrate services for the quote unquote other disorder. So substance use in a mental health program, mental health in a substance use program. In New York State, where I am, we actually have two separate service systems overseeing mental health and substance use. So it's more bifurcated by design than in most states who have merged single state authorities for care. But the tool is just intended to look across several different domains at the way in which services and structure are integrated. And this series is to use the DDCAT as a framework for informing various strategies for integration. So while we are not conducting these assessments live, both myself and Dina have done hundreds of them around the country, we are using the tool as a framework to suggest strategies for enhancing integrated care in your programs. And in many ways, after doing so many of these programs and these assessments, we see a lot of commonalities across programs. So a lot of these recommendations are really born from the many common issues and the many common opportunities that programs have to enhance their integrated care. And so this slide that you're looking at is a list of the 7 dimensions or domains that are included in these tools. And what it's indicating is that today we are going to focus exclusively on the program structure and program milieu domains. The other 5 domains will be addressed in subsequent webinars that have already been scheduled and you likely receive notification of. And so if you're interested in this in its entirety, I would definitely recommend attending subsequent sessions to hear more about recommendations for these other areas. And if you read down the list, you can see how this sort of covers really the entire scope of treatment from the point of admission to discharge, conceptually speaking. So that's just a little bit of background, about as much as I can afford to give right now. I'm going to advance the slide, but there's always a slight delay. So bear with me. Okay. This webinar is going to explore a variety of strategies for addressing integrated care in 2 domains. One is establishing an organizational culture, and the other is promoting effective coordination and collaboration between mental health and substance use services. So this organizational culture element is really a foundational piece, and it speaks to the fact that before programs institute change in general, regardless of where the change is targeted for, whether it's a specific problem or a population, something small or something comprehensive, there really has to be attention paid to the organizational culture, which has to do with leadership, has to do with line staff and everybody in between, in terms of what are their perspectives about the change that is being proposed. It really speaks to the notion that if we just implement change from the top down, it's often not effective. People want input, people want to be heard, people want to understand what's going on, and leadership wants to understand what are some of the potential barriers to implementation, you know, should they want to embark on this type of change initiative. So that's really critical. And then the other piece around promoting effective coordination and collaboration is an extended piece of integrated care that has to do with some of the steps you can take sort of outside of your organization, and recognizing that any one given organization will have somewhat limited capacity for integrated care given funding, staffing, and other resource issues. So as we move through today's agenda and we talk about the various topics related with integrated care under these 2 domains, we'll provide you with an overview of the constructs and what they mean, define them so that you understand what they're measuring, provide some recommended strategies that have come across in common across programs to start the conversation. We'll do an interview, which is in quotes because it's going to be more of hearing from Travis, who is our program provider and has a lot of experience with implementing many of these recommendations, you know, in care, in programs. So, you know, having that perspective of how this has been translated from the abstract into practice. And then as part of that, you know, you'll have opportunities to ask some questions of us or, you know, Travis or any of us who may be able to answer questions if there's any elaboration that you may seek on some of the strategies that are presented. Wanted to throw this out there as a conceptual framework for integrated care, just to keep in the background as we go through this and subsequent sessions. Many of you may have seen this quadrant 4 framework. And the idea is to think about it, again, conceptually. You'll see quadrant 2 is really how they would categorize what would be a mental health licensed or specialty care program. Quadrant 3 is really a substance use disorder specialty care or licensed program. And the idea is that, you know, you have, even though we don't want to promote primary and secondary diagnoses, that mental health specialty care tends to deal with high psychiatric severity and low to moderate substance use severity, and vice versa for substance use specialty care. And the reason why this is up there, it doesn't in any way suggest concretely how services should align with that, but it's really to communicate the important message that you always need to consider that there will be limitations in terms of the extent to which you can achieve integrated care. That notion of a quadrant 4 fully integrated care program is quite rare because of licensing restrictions in many states and other you know, funding barriers, and you know, I'm preaching to the choir, but you can imagine. So again, think about this, and it helps you to think about this in a realistic framework, not to think about it in terms of like, well, I could never possibly achieve fully integrated care, so what's the point of this conversation? Which is how most of my assessments started off, and this framework was really helpful in thinking, okay, let's adjust that expectation accordingly so that we can now openly have this conversation. So first things first, organizational culture. And as I said, prior to instituting any changes, it's critical that this aspect is assessed to ensure alignment with programmatic goals and objectives for integration. So this means concrete things like assessing staff receptivity regarding the treatment of dual diagnosis clients and addressing existing ambivalence to create buy-in. And so those two aspects, again, speak broadly to culture and the idea that, you know, while we know co-occurring disorders are the expectation and not the exception, it doesn't mean that it's the expectation to staff that it's their responsibility to treat them. You may have staff that are certified addictions counselors that don't feel comfortable or not qualified to deal with mental health disorders. You may have staff that are licensed social workers that don't have the background in addictions. We know that social work is not routinely addressed. Substance use disorders are not routinely addressed in social work programming, whether it be educational or credentialing. So I've heard oftentimes, and we've heard oftentimes in our assessments that, you know, that's not what staff signed up for. That's not what's their responsibility. They, you know, they're mental health counselors, they're substance use counselors. But the reality is that most clients, and the data varies, but 50 to 75% of clients in any given service setting have co-occurring disorders, mental health and or substance use disorders. So it's highly prevalent, and you're treating those people that are in your programs. So you really have to think about assessing staff receptivity actively to understand how you might be able to create buy-in. And we'll talk about some strategies for that. And then also looking at admission criteria, because oftentimes, whether it's formal or informal, whether it's actually something in writing, or there's just a belief among staff that certain types of clients with certain types of disorders are not appropriate for or accepted into the program, can really impede the expansion of services, whether it be admission or just the provision of treatment services while they're in care. You know, can really be an impediment if there's a generally subscribed to belief that these particular folks or people with more severe mental health disorders or whatever the case may be should not be accepted into treatment. So it needs to be addressed from a cultural perspective, but it also needs to be addressed from a technical perspective around admission criteria. And again, that may be formal or informal. Typically, it's more informal. So assessing staff receptivity. A lot of this has to do with identifying facilitators and barriers to integrated staff. And the goal is to meet staff where they're at and build from there. And so, you know, what we really recommend, you see some potential strategies there in the bullet points, but what we really recommend is that we think about proactive ways to actually explore this with staff, whether it be distributing anonymous or confidential surveys, which may be intensive and may not, especially if they're quantitatively driven, may not get at all the things that you need to get at, but it may provide you with a good baseline to see where people are at to inform subsequent more qualitative strategies. in-depth interviews with key clinical staff, focus, getting individual perspectives. Maybe in-depth interview is a very technical research term, but sit down and talk to your key clinical staff about the visions and see what their input is. And maybe they have input both on their own perspectives as well as what they think maybe the perspectives are of the staff that they supervise. Focus group with staff teams. Sometimes when you get a group of staff together, you get more rich feedback as you generate a more open discussion. And again, likewise, roundtable discussion. So I think the theme that sticks together for this is that we're actually recommending that you take this proactively to staff to have these discussions as frequently as you need to have them to get to the point where there's an understanding about the direction of the organization. Now, you may not have specifics around all the kinds of service changes that are going to take place. This might just be, for the lack of a better term, a philosophical discussion about, the need for more integrated services, pointing out the prevalence of co-occurring disorders, that these people are in fact in treatment, that if co-occurring disorders are not being addressed, they're not receiving the highest quality of care, and that there's not really an option to kick them over to another program who may have the same exact reaction and say, well, we can't, from substance use to mental health, and mental health says, well, we can't treat your substance use because it's recently active. So it's really a philosophical discussion to open the door down the line to then start, once people buy into the notion that this needs to occur, that you can start discussing more specific service changes.
Mike, are there any surveys available to assess staff readiness?
Quantitative surveys, I don't know. We would have to look into that. Dina, I don't know if you're aware. I mean, there are definitely surveys to assess staff readiness for change more broadly. I don't know necessarily if there's a survey to address staff readiness change for integrated mental health and substance use treatment, but certainly there are, I believe, surveys for attitudes towards, substance use disorders, if you're in a mental health program, towards medication-assisted treatment, opioid use disorders, and vice versa if you're a substance use program, and we can certainly recommend those. Dina, did you?
No, I'm not aware of one. No, I was just gonna, not kind of the same as what you just said.
Yeah,
Thank you.
I think the conversations, I think it's less likely that you're going to find a quantitative survey that captures exactly what you want, though, like I said, we could potentially recommend some depending on the specific circumstances, and that may provide an opportunity for sort of a baseline assessment of where people are at. But regardless, you're probably going to have these more in-depth discussions, qualitative discussions, which really are going to be more useful anyway. And so, taking it to a roundtable discussion, maybe starting with leadership and working down to line staff and thinking about it. I think the point is that we have to have these discussions, and we can't be afraid of what we're going to hear, because there has been a lot of opposition. We've seen it in the assessments that we've done, and there's not always a voice for it. And making a voice, giving staff an opportunity to have a voice for it may allow you to cut through some of the issues rather than people not saying anything, going along with the change and subverting, the actions in the background as they mumble to themselves that this is not their job. And so I think it's important to think about the value of putting it on the table. Addressing staff ambivalence, getting consensus also can be promoted by education. A lot of what, in having that conversation, a lot of the opposition is born from, not knowing a lot about the changes that you're suggesting to implementing, not knowing a lot about substance use disorders or mental health disorders, not having the experience in their career or the credentialing, licensure, whatever the case may be. And so being able to provide education, not only about just the prevalence of co-occurring disorders as a way to create buy-in around, this is here, this is what we're dealing with, this is what our clients look like, we need to be aware of this reality, but also starting to think about training that can provide some of the tools that could help people become more comfortable with clients who have co-occurring disorders and some of the service changes that are being implemented. And then as you move along, you can think about more advanced training as specific service changes are being implemented. And then thinking about admission criteria. Assuring that dual diagnosis clients are welcomed by program staff and they're not rejected because of the presence of the other disorder. Now, again, a lot of this is going to be informal. We didn't see a lot of programs that said, informally recorded in their protocols and procedures that they do not accept people with, active substance use disorders, although it has happened. But it's usually more informal. And so review those policies and procedures. If it's formal, review them and discuss how they might need to be amended to reflect the new direction of the program. If it's informal, that's going to require more discussion with staff to understand what their actual perceptions are, because they're likely to vary and they're likely to be influenced by their own bias. I mean, a lot of staff is conducting these assessments on their own. And if they have bias about particular levels of substance use or mental health disorder, they may not be inclined to conduct assessments in the same way, explore the presence of the other disorder in the same way, and therefore filtering out people according to their own bias that isn't really reflected in any, in any formal way. And so it's important to really understand what people's perceptions are about who is the ideal client or who is the client that isn't appropriate for treatment, and making sure there's a common vision for that. So I'm going to stop there. We don't have a lot of time and there's so much more we could talk about, but we're going to integrate the perspective of Travis Syringa, who was introduced previously and is the CEO at Interactive Michigan. And Travis has a lot of experience with integrated dual disorders treatment, as you heard, and implementing some of these types of strategies in his practice. So I'm going to hand it over to Travis and let him sort of elaborate on how some of this has been translated in service in his experience.
Thanks, Mike. Good morning, good afternoon, wherever you're located, everyone. Yeah, as Mike said, I've got several years of sort of experiences as sort of a boots on the ground perspective, taking kind of some of the theory of this and then implementing it in everyday work. I think probably the first thing that I would say is really if you're in the early stages of this, as best you can, have a realistic time frame. There's often lots of pressure to make changes dependent on funders or environments and things like that. But you do not want to rush this and force this on people. You're going to increase sort of the resistance to that. So I think it's important to have a realistic time frame from this. Also think about, getting information and involving staff other than just your frontline clinical staff. Your front office staff, the people who, answer the phones, anybody who's going to have any sort of contact with people. It's important to get their perspective, get their input, get what their concerns are. A lot of this on the front end, there's a lot of fear. There's often a skills deficit from staff. They just, it's not something like, you get that information that, well, they weren't hired to do this. And that may be very correct. So there's, often a skills deficit, which, then translates into some of that resistance. So thinking about over time, bringing in trainings or what's your training program look like to try to, increase exposure, to increase skill sets for staff can be really important. Addressing concerns around safety. We struggle with that a lot, particularly again in our front office staff, who kind of manage the lobby environment. There was a lot of concerns about safety and conversations about, it's trying to help them understand that there's not new people that are going to be coming in the front door. It's going to be the same people coming in the front door. You're already managing this. This is just a way to be more effective throughout the system of care that we're trying to deliver, to actually reduce the level of concern and risk. So I think the other thing is that it is certainly going to be a much easier process if the leadership of the organization is fully on board and supporting you. It doesn't have to happen that way. Some of the work that I've done in the past, and it's much more difficult, but it can start from a grassroots effort, from a supervisory level, recognizing, hey, we're providing service to a lot of these clients. We need to think about how we do this differently. And then you really want to try to figure out, how do I get allies? So that we can then start to educate our leadership in the organization about who it is that's coming in our front door. How can we be most effective? So look for allies in the community, in your organization, and then start trying to have conversations with the leadership of your organization to try to get them on board as well. And again, I'm not saying that that's a short or an easy process. That's going to be a more difficult road to travel, but it is doable. And you know, for the people that we serve, it's worth putting the effort in. I would say that's probably the big things that I've got right now, just kind of based off what Mike said. Certainly, if you've got questions, type them in. We can try to address them at the end or somewhere in the middle. So I don't know if I'm going back to Mike or Dina, but whoever it is, I'm going to turn it back over to you.
I think it's me, Travis. Thank you. So we're going to move on to the second piece of this, which is the physical environment. So, you know, this is probably the easiest domain to address, although again, we're recommending addressing culture first. If you start making changes to the physical environment and the conversation hasn't occurred with staff, people are going to be like, you know, what is all of this? But once you're getting off the ground and you're thinking about, you know, we have a unified vision for moving forward and what that's going to look like, even if you haven't filled in all the service pieces yet, you know, you really have to think about changing the physical environment in some subtle ways to be able to reflect the organizational change that you want to affect. And so, you know, thinking about it really from the client's perspective when they walk in the door, and what is it that they're seeing when they look on the walls? What is it that they're seeing when they read the mission statement that is often posted in the waiting room? A lot of it is from the waiting room's perspective, where they spend a lot of their time, but the same things can be reflected in clinicians' offices and any other common spaces that exist in the program. And so, you know, some kinds of these strategies like display and distribute literature that addresses both mental health and substance use disorders, and at times the interaction between the both, educational materials, resources, posters, videos, anything, thinking about the fact that if a client walks into a program and that client, you know, probably has prior treatment experience, most of them do, and they know that they're in a substance use treatment program, or they know that they're there for a referral that has something to do with their substance use program, but they also know that they're struggling with anxiety, depression, or anything else, and they've been, in their past experiences, kicked around, you know, because of the perception that they're not appropriate for this, that, or the other program, that what you display in your physical space conveys to them that, you know, I'm safe to talk about these things. If I tell somebody I'm experiencing serious anxiety, but I want to get treated here for my substance use disorder, they're not going to refer me to somewhere else. And it's going to sort of be that nonverbal cue to them that there isn't that bifurcation that they often experience. As we all know, the whole purpose of integration is about treating the whole person. And if they have to think about themselves in quadrants or segments or whatever, it just doesn't work that way. And so it's the display and distribution of literature, materials, any way to not just for the sake of that nonverbal cue, but also to give them, to provide additional resources that may be relevant to all the different problems that they're experiencing. And a big piece of it is the program's mission statement to reflect a dual diagnosis focus. I know it's a small thing, and I know programs, you know, it's always on your website. How many clients look at the website? I don't know, but certainly people do look around for treatment programs. It's often posted in a waiting room. Do people take the time to read it? Probably many people do. And really thinking about, how does your program's mission statement read? Does it read exclusively around substance use or mental health to the point where it may dissuade folks from bringing up the range of issues that they're experiencing? And so, you know, potential strategies to communicate this receptivity up front, you know, has to do with displaying in waiting rooms and other common areas, distributing literature about mental health and substance use disorders, display and distribute resources for community-based support, play educational videos in waiting rooms. I think many of you know about a lot of the resources are out there and ways that you could increase visibility of this focus of the program, you know, in the waiting room. And again, don't underestimate, you know, kind of those nonverbal cues and the experience that a client may have walking through the door if they see, you know, a program that seems to be kind of hyper-focused on substance use, and they don't see any mention of any of these additional issues. And so here are some basic resources. SAMHSA has some. There are a lot of places that you can get them from. We listed them here, just a couple of examples. But, you know, typically a quick sort of internet search around some of the specific materials that you want. Sometimes there's issues with ordering them in print, as that's sort of driven by budgets of SAMHSA and other places. And then, of course, there are some boundaries around cultural appropriateness of some of the brochures that you issue. For example, you know, we've done a lot of work in facilities that serve in communities and serve almost exclusively Orthodox Jewish populations. And, you know, the depiction of women in some of those surveys has to be culturally appropriate, and the availability of those materials in a culturally appropriate manner may be quite limited. So you really have to think about, you know, what would work best. You know, that there's not always a solution that's ideal in every circumstance, but certainly think about and research where you can obtain these types of materials. The mission statement, again, communicate dual diagnosis focus of treatment services. It's emblematic of a sea change in programmatic leadership philosophy, culture, and commitment. Don't underestimate what it means. And so the revision of the mission statement will reflect an emphasis on both disorders. If it can't be revised, I think this is one important thing that really came up. I think many of us have really sat on these committees that are charged with revising mission statements that need a lot of approval, get wordsmithed as nauseum, and it's actually much of a bigger deal to change a mission statement than we often think of. You can think about developing a unique program statement as sort of an addendum to the mission statement, as maybe an easier way to sort of circumvent that process to the extent that it exists. And then make sure that the mission statement is posted, you know, widely available, so that people continue to see this. And when we think about revising a mission statement, here's an example. We're not talking about a substantive, comprehensive revision that is all that specific about the types of co-occurring disorder services you provide, but it really just sort of is a subtle change to open up the conversation. So there's an example here for substance use treatment provider. I'll let you all read it, but the Northside Drug Treatment Center is dedicated to assisting persons with alcohol and drug problems regain control over their lives. You see in that mission statement, it's specific to alcohol and drug problems. And in the revised mission statement, it's dedicated to assisting persons to initiate a process of recovery from substance use and its associated problems, right? So a very subtle way to sort of open the door. It doesn't explicitly mention mental health, with many agencies might balk at if they're not licensed to treat mental illness. But it sort of shifts the focus enough so that clients understand that there is a broader emphasis, you know, on their regarding their issues. And another example for a mental health provider, again, the first example is mental health specific. The second example references a full range of behavioral health services to promote well-being and lifelong recovery. And so again, it's not always explicit. It doesn't say we provide mental health and substance use treatment, but it certainly broadens the focus. So again, I'm gonna turn this over briefly to Travis in terms of, and I know these are almost kind of speak for themselves, Travis. So, but if there's anything that you've done that you can share with the group that maybe would, you know, provide some innovative strategies, you know, that would be wonderful.
Yeah, I would certainly want to emphasize even if it's difficult to change the mission statement, the work is well worth it. Again, it really just emphasizes the cultural shift for all of the staff and the people walking through the front doors, and for your community. So I think it's really important to really put some thought and some time into that. Resources, I think, again, anything that you do, you know, as we developed our co-occurring disorder capabilities in our programs, we started developing specific brochures for the different modalities. So whether it was individual therapy or group-based treatment, we would have specific brochures that addressed the co-occurring focus of those services. So then, you can have those brochures sitting out in the lobby for people to just pick up and take with them or just see. You can have them sit out in community somewhere. Depending on how your systems are set up, sometimes you might have an access and referral center that's separate from where you are. If you can have those brochures in those locations, again, just out in community drop-in centers, all of those spaces where you can have information about your co-occurring services can be really helpful. I think I want to go back just quickly even to the previous thing. One thing, as I was talking about, sort of being realistic over time, and sometimes, like you say, staff aren't necessarily hired to provide a co-occurring service, and yet we all have turnover in organizations. So just another strategy I want to throw in there is, as you look to hire staff who are capable for both. So just wanted to throw that in there as another strategy. So I'm going to turn it back over to you, Mike.
Yeah, that's very important. When you have the opportunity to hire staff that, are duly licensed or credentialed, that's great. There are certainly limitations of such individuals in certain more rural areas, but wherever possible, absolutely. Thank you, Travis. I think this
I
is
think I'm up.
Dina, so if she can have control of these slides, that would be great.
Yeah, so one area, and we're not going to spend a lot of time on thinking about your certification and licensing because that's really unique to every state. It's hard to speak to it generally, but just a few things I wanted to say about this. First of all, I guess, hello from Portland, Oregon. Is this idea that if you want to reach the highest level of integration, having licensure and certification to treat both is essential. But sometimes that just isn't realistic. And so one of the things in doing these reviews of programs is this idea of actual barriers versus perceived barriers. And so, like Mike talked about, there is kind of the formal and the informal. And so, just to give an example, I remember I was doing a review with one program, and it was very clear that, the staff, and both the staff and the clients were very clear, like, we're here for our addiction issues. We're not here for our mental health issues. And so, okay, so they may not have had license to provide mental health services, but when you think about, can they talk about those in the context of the primary disorder? And so talking about somebody's substance use disorder, but also saying, how, at least addressing the mental health and talking about it and the need to actually get services for it is key. And so all of these different areas actually end up integrating together, because if you start to change the culture, people still need to work within their scope of service or practice, but can they, one of the things I used to say is, well, talking about doesn't necessarily mean that you're treating it. So you might not have the licensure to treat mental health conditions, but you can definitely talk about with the person what they see, what the interaction they see, and to also talk about the need to secure those services. So of course, like I said, actually looking at that scope of practice, looking at licensure, so what the actual perceived barriers are versus actual barriers. Let's see, I think, oh yeah, it worked. The financial incentives, of course, is really tied closely to the licensure and certification. So, but can you bill for both mental health and SUD services? And if you can, of course, you're going to have the highest level of integration. I remember one program, and it was really clear and evident once again that the clients, the staff, this was a truly kind of fully integrated program. And the staff, when you would, or the clients, when you'd ask them about, well, do you feel like you can talk about your mental health programs? And I love their response. They're like, they're just treating me. They're treating me as a whole person. So, and, when you then looked at this program and their funding, they had some special DOJ funding. And so they were able to have a rate that really allowed them to provide fully integrated services. The partnering with and so, there's been some really creative strategies around this. Actually to partner with a program or even an individual who can come in and provide the mental health services and bill under their own license, but to get integrated into the staff has worked really well for some programs. There are many states I know, both in Washington and in Oregon, where I do a lot of work, that are providing higher rates for programs that are offering co-occurring disorder services. Or, sometimes this is an opportunity where if you can secure a grant to enhance services, it helps a lot. But like I said, those are the areas that, take much more time and effort. And, you may or may not want to go that route. But even if you're not fully licensed or able to provide both services, I think the key area is collaboration and for effective care. Now, when you look at integration models out there, there are whole models that are focused on care coordination. But even just looking at within your program, there are lots of programs that have both a mental health and SUD license, are able to provide both care, but I remember years ago when I worked at a mental health organization, and interesting, that was the name in the title of it. We had a chemical dependency program, but we were so separate, even though it was the same building. But if people were receiving both services, there was no true coordination or communication between the two programs. So before we get into some of the strategies around collaboration and coordination, I encourage you, if you have a few minutes sometime, to watch this TED Talk by Ken Blanchard. He wrote The 1 Minute Manager. It's a great TED Talk. But in it, one thing that he talks about is when you're thinking about collaboration and coordination, collaboration, it's great. He talks about having written, I think, 50 books, and all but 2 of them he had collaborated with other authors to write the book. And he tells this great story about collaborating with Norman Vincent Pearl, who wrote The Power of Positive Thinking. And he wanted to write a book in that area, but before he connected with Norman Vincent Pearl, he talked with one individual, and he was talking to this individual, and all the individual could really focus on was the form, like how are we going to split the royalties? How will we do the work? And he walked away so discouraged that he decided, you know what, I don't think this is going to work. And so somebody suggested that he consider collaborating with Norman Vincent Pearl, and so he did, and he met up with him, and he talked about how it's really the essence that matters. And I think sometimes we forget this when we're doing collaborations. So even if it's a program outside of your organization, or if it's a program internally, have you really sat down and talked about the different, Mike mentioned this, the different philosophies? Like what are our mental models for how people recover, about how the interaction of mental health and SUD actually happens? And so really having those conversations and forming relationships. One program that I was working with just decided they had a mental health agency. They were more primary SUD, and they had a mental health agency, and they decided to actually invite them over for a get together and have some food and talk with each other. So first of all, it's really about forming those relationships, getting to know people, understanding their perspective, so that the plan at least can make sense to the person. So it is about treating the whole person, and it's about doing seamless services, so the person doesn't have to figure it out. So often, when they've done focus groups with the customer, they say, like, I'm confused. My mental health counselor is telling me to do this thing, my SUD counselor is telling me to do this thing, and I'm confused. And so talking with each other and coordinating those services is really key. So what are some strategies for that? I think one of the biggest ones is to have multidisciplinary staff meetings. where I was really fortunate early in my career to work in a dual diagnosis facility. And I remember, you know, we had the psychiatrist there, we had a psychologist there. We would, on a weekly basis, consult on cases. And I learned so much more from that as a SUD professional early in my career, because you have the training and during those staff meetings of really learning about how the different disorders were interacting and being guided by that. That's not always possible, you know, depending on funding, but whenever possible. And, you know, now that we are in this virtual environment, you know, I think we're getting more comfortable with virtually being able to do some of this. Having MOUs in place, regular check-ins, formalizing the communication. That's one of the things that we look for when we're working with organizations and they're looking at integration. How formalized is the communication? How often, you know, is it set up so automatically if you're referring somebody for, say, mental health services, that you receive a copy of the evaluation, that you can note it in the records? I think, once again, right now is a key time to actually be able to provide some telehealth services and to coordinate maybe with there's many organizations that are doing mental health telehealth. Could you actually integrate that? Co-location of services definitely helps, but once again, just because you're co-located doesn't necessarily mean that there's high levels of coordination. Shared patient records, if that's possible, that's so important. I know I was talking with, there's an organization called OCHIN in Oregon, and I think it operates in several other states. And they actually, and this was more with physical health and integration, but being able to pull up the records, which oftentimes, because the firewalls prevent that, but when it's possible, there's more communication. So when we think about this whole thing, SAMHSA has identified 4 levels of coordination. Minimal coordination, and so just kind of thinking about where you might fall on this continuum, and they're not necessarily discrete points, but minimal coordination might be that the program is aware that the person has a mental health or SUD condition, that they actually make a referral, but there's no actually minimal or little communication or follow-up. So an example, you know, Bob, Program A refers Bob to the county mental health program after screening positive for mental health issues, but doesn't follow up on the referral. Consultation means that there is more of an informal process. So between 2 providers, this is who we refer people to, and we, you know, do get back a copy of the evaluation, but we don't necessarily have ongoing communication. In collaboration, then you start getting into where there really is a partnership between 2 programs, or even if you have both services within one program, you meet regularly, there are joint case staffing, MOUs are in place. And fully integrated is where then you do hope that you're seeing somebody who is duly credentialed and they can address mental health and SUD issues really through the lens of COD treatment. There's a combined manual. I think some of Hazelden's program or COD treatment is based on some of the combined manual, where it's really integrating the 2 disorders and helping the individual understand about the integration between the 2 and how it's affecting. So just keeping in mind that as shared responsibility goes up, so does the level of needed communication. So with that, I'm going to ask Travis to jump back in and talk about some of what you've done in your program around the coordination and collaboration.
Thanks, Dina. Yeah, that's really huge early on. I got a big echo here. I was on my phone.
You sound okay from this end.
Okay. All right, I'll deal with it over here then. Yeah, the collaboration is really important, particularly early on, as you're not going to have a lot of resources. You know, if you're a primary mental health provider, you're not going to have a lot of resources on the substance use side, and then vice versa. Some of the things that we really looked to do was collaborate with other community treatment providers. And so initially those were informal conversations, but we come to recognize that generally, you're running a group anyway. And so oftentimes the conversation goes to who's billing for what, or how do we get paid? That's usually some of those first questions that come up. We were able to sort of address that as you're running the group anyway. So to have one or two people coming in extra is not, I mean, you're billing for those people in that group typically anyway. So we would have some of our people from a mental health organization engage in a substance use group that was in the community. And then we would also reciprocate that. We would have some of their individuals come over to our groups. As we progressed along, what we did is we actually co-facilitated using our staff. So we would have one of our staff from the treatment team co-facilitate with their staff during their groups. That actually, we got some understanding with our funders that we could then bill for the person or people who were in that group from our programs. So again, that sort of came down the road as we had things going and people saw that it was working. So those are some strategies that that worked for us. The licensing is, the licensing, that billing, again, those are usually the first questions that come up, and those are, if that's where you kind of stay focused early on, you're going to get stuck there. It's really hard to resolve those on that front end. So, so try to, if you best you can, just set those aside initially. We kind of took the philosophy, doing something is better than doing nothing, even if they're small steps. It's better for the, again, as we talked about earlier in an earlier slide, the essence. Providing some co-occurring treatment is better than not providing any co-occurring treatment. So small steps are better than nothing. And then again, with a realistic time frame, as things progress down the road, you can kind of build momentum in a community, again, as you gather those allies. And then, you'll find yourself making some pretty significant strides. As long as you stick with it. But that's what we do. That's what we do in this work is we stick with it. We advocate for our communities and the people we serve. So if you kind of keep that attitude and mind frame over time, you'll be successful.
Yeah, exactly. That idea that, sometimes programs will try to tackle these big areas and kind of feel overwhelmed with those. So I love your point of like those small steps all add up and they make a difference in the long run. So, thanks, Travis. I think we have some time left for some questions and answers. David, do you want to give us all some questions?
There's a couple, 3-4 questions that came in, and the first one relates to billing. And while we didn't cover a lot of that there, maybe we can comment a little bit. The question was, has anyone here provided residential services for both mental health and substance use disorder services? And how do you bill this to Medicaid and not run into the issues of duplicate billing? Anybody, any ideas there?
I don't. Travis, have you run into that at all?
I don't have any experience with sort of residential treatment and billing. I mean, the way we're set up now, we're able to bill whether we're providing substance use or mental health treatment in our program. So we don't have an issue with dual billing.
Okay.
Early on when we first started, there were 2 completely different funding streams, and that was a challenge. I mean, and kind of like what I said earlier, if that's where you start and get stuck, you will get stuck there. Sometimes early on, you got to try to skirt around those edges and be creative.
Okay. Well, here's something a little different. Your opinion, the SAMHSA's TIP 42 substance use disorder treatment for people with substance use for co-occurring update 2020. What do you think about that as a good resource?
This is Mike. I responded in the chat because I didn't know if we would get to it, but I mean, the TIP 42 obviously itself is old. I'm glad to see that it was updated, but I mean, it really is a great resource, kind of the Bible, if you will, in many ways around thinking about the various principles of integrated care. And you'll see a lot of what we talk about throughout this series sprinkled throughout the tip in terms of providing additional guidance on operationalizing some of these recommendations. I mean, you know, nothing ever sort of goes as far as giving you the kind of guidance you need to apply something to the realities of your particular program. There's always translation involved, but you know, the tip is definitely one of the most comprehensive resources out there on best practices for integrated care.
And is there another resource? Somebody was looking for manuals that combine substance use disorder and mental health treatment as a about a how-to. Any ideas about that?
You know, I saw that comment actually, and I have to look. The combined manual itself, it was free. I think it might have been NIAAA that distributed that. I haven't been able to find it lately, but a lot of that, you know, that would be the free resource. We're going to touch upon this when we get to the treatment section, so we'll do some of our research to see if we could actually find a resource link to that. You know, Hazelden has taken a lot of their material is very similar to what's in the combined manual, so they have a full COD curriculum. There's several different manuals. I know a lot of that is integrated. Of course, you know, that isn't a free resource, but we'll definitely provide some of that when we get to the treatment, which will be the 4th webinar in the series. So we'll definitely provide some of that.
Okay.
Oh, and it looks like Brian Hartzler, who is like their director at the Northwest ATTC, said he thought maybe the CASA website might have that manual.
Okay. Fantastic. Another question, this one's from Frank. How well is DBT received in co-occurring programs? Any thoughts?
I'll just say from the providers, at least from in the space that I work in now, we expect it in our DBT programs that there is going to be substance use issues. Again, part of that kind of that whole welcoming environment. And then even vice versa, we have DBT participants involved in our co-occurring disorder groups as well. It's not a rule out by any means.
Okay.
I guess I would just see, I've seen a lot of programs who do have integrated DBT as part of their co-occurring disorder. My understanding there is actually a DBT supplement that is specific to SUD as well. I haven't actually seen that resource, but I've heard about it.
Okay. And our audience members are wonderful. Folks are posting some options in the chat box. Folks can take a look at that and click on some of those links. I'm getting a sense we got like 2 minutes. Any closing remarks from you all, and then I'll do my closing remarks. So I just want to pause there.
I would just say, this is Mike, you know, a lot of these treatment questions are coming up, which is great, because that's really the meat of what's going on. And we didn't ignore that. We are dedicating a whole session to treatment. But I think without kind of giving a spoiler for that, whether it be DBT or whatever else, seeking safety was just mentioned in the chat box. You know, those are program-specific considerations based on client need, what your population looks like. There is really no model for integrated treatment per se. Sometimes it's just psychoeducation about the other disorder. Sometimes it's about the interactivity of the disorder. Sometimes it's about psychotropic medication, medication assist. I mean, it really, what we'll talk about a lot is about really assessing what are some of the priorities for treatment for your program, because you can't do it all. Mm-hmm. And so that's sort of a teaser to tell you to come back. I know someone just asked if signing up for this session gets you signed up for all the other sessions. David, maybe address that quickly, just so people understand.
No, they have to register for the next one. And if we're doing a really great job, we're going to send you the link for the next one. So we'll pay some attention to that and make sure that you get it. The next one is August 19th, and it's called Best Practices for Co-occurring Disorders Treatment, Staffing, and Training. So that one's the next one coming up. Okay, so I think I'll finish with some of the business, and the business is big thank you to Travis. Thank you today for being here. Dina, thank you very much for being here. Mike, appreciate your time, and to the 300 plus people that took an hour of their day to participate in this. Thank you very much for joining us today. We'd love your feedback. We have a survey that we will send you tomorrow. I've also dropped it in the chat box there where you can click on that. It's a very short survey. We'd love to get your feedback about how we're doing. We also, everybody that signed up today, you'll get a certificate automatically. If, however, you are with a group of people, email us at this address on the screen and give us the names of the people and their email address, and we'll make sure that we send the certificates to them. Otherwise, they're automatically coming your way. And I think that's it. So then the next slide, obviously, is the one that was telling you about the upcoming presentation. And then a big thank you to everybody. I think that's it for today. And we thoroughly look forward to seeing you at the August 19th webinar. So thank you, panelists, and thank you, participants. Bye-bye.